Hello everyone and welcome to our Softfield Academy webinar. It is a pleasure for me to welcome everyone tonight. My name is Hannah Tebeka Azriel and we are honored to have Dr. Javier Beut from Spain with us to present this Softfield Academy webinar. Welcome, Dr. Beut. I will start with a short introduction about Dr. Javier Beut, if some of you are not yet familiar with who he is and his past. So he is an aesthetic and reconstructive surgeon. He developed several non-surgical techniques, such as the non-touch lips enhancement, volumizing viaduct of the mid-face technique. He is a pioneer in cadaveric studies, and he is known for advanced 3D videos and live demonstration that you will witness also tonight. He's the director of a 2-day surgical and non-surgical facial rejuvenation and cadaver lab course in Palma de Mallorca. Also an international speaker at major congresses and academic institutions. And last but not least, he is the founder of Cirujanos Plásticos Mundi, a non-profit organization that supports humanitarian surgical missions in underdeveloped countries. So it is truly an honor to have him tonight. We will see tonight beautiful live demonstration using the Softfield cannulas. And after, there will be some time to answer your questions. So don't hesitate to put all of your questions and to write them in the Q&A or in the chat of the webinar. Just as an information, this webinar is being recorded and it will be available with subtitle from tomorrow on Softfield Academy's website. So tonight's theme is the power of precision, safe injections in high-risk zones. We will now start the webinar. Again, I invite you to ask any of your questions along the webinar in the Q&A and in the chat, and we will answer all of the questions at the end of the presentation. Thank you.
So, good morning. Today we have a special case with Andrea. Andrea, she's 37 old. She's just 37 and she's perfect. I don't know why she's here. Anyway, the fact is, as you could see, during the analysis with Vectra, she has, I think the only thing she needs is a little bit of chin, because not just the chin. The fact is, when we treat the chin, we don't treat the chin. I like to mention the area, because if you treat just the chin itself, you can have, maybe not immediately, but you can have what I call double chin. So that's why I like to when I treat my patients, I like always to mention not just filling holes, but, treating special areas. And so I'm going to make the middle line. Abre un poquitín la boca. So to see the middle. All right. So the fact is, the chin maybe is just this part, but that for me, it won't be enough. Why? Because you just project this part. And so what I'm going to do is I'm going to lengthen, like 2 wings, like that. All right. With one single entry point. Why one single entry point? Because we want to feminize our patient. I mean, when I do men's, I like to do 2 single points, and then to make this a little bit more square. But doing like this, I can manage, with the cannula. And then where I'm going to place my product. The product is going to be deep, just because we're going to use shape from Brevanès to give, the enough support. Because every time when we took when we work of support spaces, we need a high G prime product, with high elasticity, to support all the forces. So we're going to work in this region, all right, with some shape. So what I like to do all the time is, this is the way I like to do every single, port of entry. I like to use some local anesthesia with epinephrine. It has been demonstrated, from many analyses that the problem with the embolisms are due not really to the main arteries, but to the perforators. So in this region, we have from the sublingual artery, there is a connection, to the tongue. So it has been, it's very rare, but it happened, that you go with a needle and then you can even create an embolism, to the tongue. So this is the first thing I do is, I don't use needles. I'm going to use cannula to prevent, and to augment the safety of the patient. So the fact is, now I have injected this area. The ideal thing is to wait 5 minutes to obtain a nice vasoconstriction, and but now I'm going to make the markings for the tear trough. The markings for the tear trough are the following. I like to mark the nasogenital groove, and then I mark 1 centimeter above the nostril, like that. Even in the other side too. Okay, and in her case, mira para arriba. Okay, and then I place a line, from the mid-pupillary line, like that. Another one like that. And then, if you look carefully, when she moves, her, up gaze, she is pushing, all the orbital septum. And the orbital septum, what does is put on the tension a very strong, structure called the arcus marginalis. So when we see if there is an indentation between the lid and the cheek, like this one, all right, is in between the arcus marginalis and the orbitoroidal ligaments. So if we look to our patient, I'm going to make, just one drawing like that, another one like this, another one like this. We have the pretarsal, we have the preseptal, and then we have, the orbital one. And the orbital one, in her case, I think is slightly lower, like that. Okay, and remember that sometimes the orbital part reaches, the ear. It's very rare, but sometimes happen. So if you look to her, what happened is we have in this region, we have what I call, this is the tear trough ligament. But the tear trough ligament is composed by, is an osteocutaneous ligament, and then what happened is formed by the preseptal, orbicularis, and then the orbicularis orbital, and where is lying this orbicularis orbital? Over the cheek. So whenever you try to restore the tear trough, the standard way is to make, one single incision from here, or with a cannula, or with a needle, or from this part. But what do you obtain when you do this? What you are just filling a hole. But my conception is that I'm going to fill